Schechter. I'm a general dentist and I practice in Toronto, Ontario, Canada. I've been in practice for almost 30 years and have had the good fortune of being involved with dental implants since its first introduction to the North American marketplace back in 1982 here in Toronto at the Toronto Implant Conference. I utilize dental implants as a integrated part of my treatment planning and will not rely on implants as a last resort, but will look at it as a primary treatment option where needed when teeth are deemed to be hopeless. And today we're going to be doing a live surgical procedure on a recently extracted upper right first premolar tooth, and this will show the dental profession that it is feasible to take out a tooth, even a multi-rooted tooth, and place a dental implant into the available bone and do whatever is needed to augment the defects in the bone, to provide stability, and then to as well give the patient a immediate tooth replacement. The implant is really has to be considered only as a root replacement, but really what patients are concerned about is their aesthetics, their function, their esteem, their smile, and it's no longer acceptable to just go back to the original Brandemark protocol of early implant dentistry, where we would place the implants, cover them up, and then just leave them alone for 4 to 6 months or 3 to 6 months, and then subject the patient to a second surgery. But in that interim healing phase, the patients would be grossly inconvenienced and would have to usually wear some type of a temporary restoration that they really couldn't function with adequately. So the purpose of what we're going to do today is to show you how, even in a difficult situation, slightly compromised, we can place an implant, we can restore the missing tooth space and give the patient what they want, and that's a visible tooth. And we're going to show you how to do that. The patient that is in the chair to have this procedure done on is a relatively young male in good health who had a severely deteriorated upper right first premolar tooth where the roots were decayed and the tooth was non-salvageable. We extracted the tooth, and for this surgical site we're going to be using the new Nobel Active implant as developed by Nobel Biocare. We've chosen this implant because it will allow us to place the implant into this site, which otherwise would normally have to be left unattended for 4 months to allow healing for the bone to fill in. This implant has very specific properties which we will explain as we're going along in the procedure, but the most important thing is that this implant is self-cutting, it is very sharp, and its apical grooves allow us to have a minimal osteotomy preparation site, and we can engage the bone and actually reorient the implant in the available bone into the exact perfect position to receive hopefully an immediate temporary. We will also go through this morning the protocol for deciding and electing whether we can do an immediate temporization, and hopefully the bone will prove to be sufficiently sound to allow us to do so, and then we will show you how we can fabricate an immediate temporary. So this x-ray here that you see on the screen is the post-operative radiograph of the extraction site. As you can see, there are 2 root sockets left, and we're going to be penetrating through from the buccal through to the palatal socket and up into the host bone up here, and then I'm going to be manipulating the implant and reorienting it so that the implant will be hopefully, as we call, dead center in the middle of the socket site. And as one could imagine, this will leave a void on either side, which we are going to be filling with some bone grafting material, which again we'll talk about later. And we will then close up the site and be, as I said, hopefully able to make an immediate temporary. So I'm going to just now pull up the Panorex, and this is the panoramic x-ray of the extraction site. And as you can see here, there is a prescribed calibration pin that we place onto the film before we, or onto the patient before we take the Panorex. And I'm going to use my calibration tool to calibrate so that I can know how much available bone I have. So this pin is actually 20 millimeters in length. It measures 11.6, as you can see. So all I'm going to do is recalibrate to 20. And then I'm going to choose my site where I want to go. And I have 13.5 millimeters. So I'm going to be putting in an implant that will be 13 millimeters in length. So what we're going to do is make a very small sulcular incision around the adjacent teeth. And as you can see, we got really nice healing in 24 hours. And I'm going to reflect the tissue back completely so that I can actually see the site. And when we do this, I want to be able to peel this back so I can actually see the bone completely exposed. So I'm just going to spend a few minutes here just cleaning this, getting rid of all the tissue that I don't want. That's good. You see, I've got a good buccal plate here, which is what I want. Now I'm going to do the same thing on the palatal aspect. But I'm going to just undermine this a little bit. So the key to good tissue management is really in the initial flap design, just to make sure that everything's nice and clean, and then it will suture back really nice and easy. Now we're just going to take a spoon curette. We're going to clean everything out that we don't want. So that's pretty good now. We've got a relatively exposed, clean surgical site. We have a little bit of a defect over here next to this tooth, which when we do our bone grafting, we're going to fill in as well. And we're back down to the original socket. Second here. So just to make life easy, I'm going to just pull the tissue out of the way. So I'm just going to suture the palatal aspect of the flap out of the way, so it'll make life easier for me. And obviously with a patient who has a beard, you want to make sure you just suture the suture, not the beard. I'm going to wrap it around the tooth just so I can keep the this allows me to keep the palatal tissue out of the way. So if you look at this, there's an oblong shape to this socket. Here's the palatal root. Here's the buccal root. So if we could reorient for everybody. This is the buccal root space. This is the palatal root space. And there's a tiny little piece of septum here in the middle. What we're going to be doing is we're going to actually penetrate this septum like this, angled a bit towards the palatal, and I'm then going to be manipulating the implant when I place it and turning it vertical. So the orientation of my drill is going to be towards the palatal where there's more bone. And I want to preserve this buccal plate because the buccal plate is much thinner than the palatal aspect. And I'm going to go apical to where the root is. And then I'm going to, as I said, when I place the implant, because this implant is self-condensing, it's going to allow me to push the bone from the palate towards the buccal and help fill in the empty space on the buccal aspect. This here is our surgical kit for the Noble Active implant system. It has all of the drills in 2 lengths. So these are the exact same drills that are used for putting in any straight-walled Nobel BioCare implant, whether it's a replace implant or a Brånemark external Hecht implant. It has each drill in 2 lengths. These drills on this row here are 7 to 15 millimeters in length. These drills down this row are 10 to 18 millimeters in length. And I want to put in a 13 millimeter implant. So if I take my pilot drill, and you can see all the drills have marking lines on them. Every drill has a series of lines on it that correspond to various lengths. So on a 10 to 18 millimeter drill, you're going to have a 10, a 13, a 15, and then an 18 millimeter line. So we're going to be drilling 13 millimeters, so we're going to go to the second line. And in any straight-walled implant system, what you want to do is start with a very small diameter drill, which is our pilot drill, which is 2 millimeters in diameter. And then we're going to slightly enlarge sequentially the hole until we get to a size that's going to be just slightly narrower than the implant. So the implant body itself will cut its way through the bone. And that creates the stability for the implant. So we're going to start with our pilot drill. We're drilling at 2,000 RPMs, again, which is a higher speed than the tapered implant system, because these implants are much more efficient in their own cutting. The tapered implants don't cut, and therefore we have to drill at a slower speed and preserve the bone, and the implants are put in to a different torque setting. So, as I said, I'm actually going to use, just again, this here is a drill extension piece. So I'm going to put this into the handpiece, and it allows me to have a longer working length so that I can seat the drills into the extension piece. So the hardest drill is really your penetration drill. A lot of water. So that's my pilot drill. I'm now going with a 2.4 diameter drill. It's actually 2.4, it's called 2.4, 2.8 because it starts at 2.4 and then it flares a little bit to a 2.8 diameter. And actually I can feel that there's more bone, so I'm actually placing I'm going to place a 15 millimeter implant. I only took out a 13, you're going to have to take out a 15 millimeter. So this here is my 2.8 3.2, and now I'm actually going to go up one more step because I'd really like to put in a 5 millimeter diameter implant. Now it's 5 millimeter diameter on the body, but in the Noble Active system, the top of the implant, the restorative table, is the same. So you can see I'm angled a little bit towards the palate, which is fine, because I'm going to re-angulate it with my implant insertion. So this here is a 3.8 4.2, and I'm not actually going to drill the whole length of it. I'm only going to open up the top part. The implant itself to grab the rest of the bone. And that's it for the drilling. That's how quick it is. We can use the handpiece with a driver. So this is a surgical driver. This driver is inserted into the implant head. And this would go into the handpiece, and then we would pick up the implant and place it under a controlled torque insertion of no more than 45 Newton centimeters on the torque setting. Okay, another way of doing it would be to use the hand wrench, and the hand wrench has a movable attachment that you place the driver into the attachment piece, put it into the wrench, and then we can go ahead and we can insert the implant that way. A more controlled way is to use a hand driver. This is the hand driver. And again, we place the driver into the hand instrument. I'm now going to open up the implant. The implant comes, first of all, labeled in a sterile package. It's got a double seal, so you strip this down. This is a 5 by 15, so it's a 50 millimeter long implant in the Noble Active system. It has a peel-off label on the vial, which verifies that it's Noble Active internal connection, 5 millimeters by 15, and it has a reference number and a lot number. It's very important to keep this information, because we take one of these labels, we put it into the chart, and that way we have a permanent record of what's in the patient's mouth. If there should be a failure of any kind, the implant company will warranty these implants and replace it at no charge. So it comes in a titanium sleeve with a cover. This here is the implant.